David Geffen School of Medicine at the UCLA, Los Angeles, California, and he's a co-founder of Figo's Committee on Menstrual Disorders and Related Health Impacts. He co-led the development and publication of the, in the meantime, famous Figo system for abnormal uterine bleeding in the reproductive and classification systems for adenomyosis, leiomyomas, and ovulatory disorders that apply to infertility and recurrent early pregnancy loss. Dr. Munro also led the development and publication of the EMIC system for training and testing gynecologic endoscopic psychomotor skills, now required for certification by the AAGL and the American Board of Obstetrics and Gynecology. He has published 3 textbooks, 3 edited volumes, over 45 chapters, and more than 150 publications cited more than 14,000 times in the peer-reviewed literature. Professor Munro will be speaking on mapping the fibroids landscape, epidemiology, pathogenesis, and classification.
Thank you very much, Ivo. And greetings, everybody, wherever you are in the world listening to this webinar. We have a lot to get through. This is the agenda that I have for you in these next 13 minutes or so. And we're going to start out with epidemiology. And of course, the lifetime prevalence of leiomyomas in women pretty much throughout the world is about 75%. And it increases with age to menopause. There's a relationship that seems to be earlier onset of Black women versus Asians and whites. Early menarche increases the risk. There's a association with parity, and that with increasing parity, there is a decreased risk, or if you're nulliparous, you may have a 2 times risk. There is a familial association, and there are issues related to lifestyle, diet, environmental issues. Here you can see the potential impact of vitamin D deficiency. Vitamin D seems to occupy the vitamin D receptor, and that has downstream effects that adversely impact either the development or the growth of leiomyomas. And with respect to hormonal contraception, there are mixed data, but there may be decreased risk or perhaps decreased growth rates with long-acting progestin contraception. I do want to spend a little bit more time on the age and race circumstance because this is sometimes unclear. If we look at the prevalence here in green, and these are prevalence studies synthesized by Ebby Stewart a number of years ago, you can see that the Black women, which is the solid line, versus white women, which is the dotted line, you can see that for women of African ancestry, there is a far earlier onset of leiomyomas. When you look at prevalence, you can see that by the time they're 50, and this is actually incidence, I'm sorry, and these are data largely accrued by Donna Baird and others who have done longitudinal studies, you can see that there is a difference. But by the time one gets to the age of 50, at about the time menopause starts, there isn't a lot of difference between the 2 races. So what is quite dramatic is that in this reproductive age group, say between 25 and 40, there is a substantial difference. And this is where we get this 3 times incidence greater Blacks versus whites. That's not quite correct. It's that it's 3 times in this reproductive age group. Well, what about pathogenesis? Well, leiomyomas generally start with a genetic hit, MED12, HMGI gene. This could be even in utero. We're not sure. And then once there is production of gonadal steroids from the ovary, particularly progesterone, we get clonal growth of this tumor. And so that led by progesterone, but set up by estradiol, which really produces the progesterone receptors, we start to see this clonal growth. and enlargement of a tumor. And then the tumor manufactures or expresses a number of entities that may adversely affect function in the endometrium, either with respect to local hemostasis or fertility, which we'll speak about later. So the issue about what causes leiomyomas to grow, there are three myocyte populations in leiomyomas: the well, intermediate differentiation, and then fibroid stem cells, which are about 5%. And the tumor growth may vary dependent upon the relative proportions. And not surprisingly, in women of African ancestry, there is a higher proportion of stem cells. And there are also variations in the expression of hormonal receptors and, of course, the hormonal levels. And with respect to the extracellular matrix, which is responsible for that, the collagen largely, but other expressions as well, but largely collagen, that's responsible for that dense, firm tissue. Those are not mutated. That's not mutated tissue. Now, just to demonstrate the growth impact, if we look at estrogens only and follow them across time, we won't really see growth at all. But if there is progesterone in the mix, and probably it has to be cyclical so that you can repopulate those receptors, otherwise they're downregulated, we see volumetric increase in the myomas. Very important to understand that. Now, classification, why bother? A lot of people say, well, who cares? And there are lots of good reasons. First of all, for basic translational research, it's important to understand the relationship of the leiomyoma, for example, to the endometrium to help determine which myomas actually are relevant from an endometrial perspective. So this allows the design and the curation of populations and studies that are similar. It can inform which ones may be relevant and help to design, if you will, and evaluate the impact of pharmacological and even procedural interventions. And it even can facilitate epidemiologic studies. From the trainee's perspective, understanding that information, it becomes easier to consistently teach students, residents, and fellows. After all, if you have something that affects 75% of women, but most of the times is asymptomatic, it's important to know which fibroids count. And of course, then that translates into clinical care and helps with clinical decision-making as well as procedure feasibility and appropriateness when you're talking with patients. The classification was really started by Kees Wamsteker, published in 1993, who really was focused on the hysteroscopic management of fibroids and came up with the type 0, 1, and 2. So later in 2011 and then revised in 2018, our leiomyoma classification system of Figo was based on this. But we had to create other myoma types in order to comprehensively look at this. So we really had a simple level of classification. Do you have a fibroid or not? But then the second layer is it submucous or not? But then the detail that we really go into are provided here. So you can see that we have really a number, 5 kinds of submucous myomas. Wamsteker's original type 0, 1, and 2, but we added a type 2-5, which is really important, especially, but not only for the hysteroscopic surgeon, because that tumor is in contact with both the endometrium and the serosa, so that hysteroscopic removal really is not possible. And then we also added the type 3 myoma that doesn't distort the endometrial cavity, but is in contact with the endometrium, which has turned out to be a relatively important categorization. The intramural myomas now are basically those surrounded by myometrium. And then that leaves us to the subserous myomas that are really these type 5, 6, and 7, 7 being the pedunculated. And then, of course, the 2-5 is also subserous. And finally, the type 8, and mostly that is the cervical, but we also have included the parasitic, some of those other unusual tumors that occur. I hope that in the future we're going to be able to further refine that and separate those out. There are other classification systems. Ricardo Lasmar has developed a system really to help, when you have a submucous myoma, help you determine the feasibility of making that occur. And it has more to do with where in that cavity the leiomyoma is, how big the leiomyoma is, and there are data suggesting which of those categories is more or less likely to result in successful hysteroscopic myomectomy. Now, the final piece I wanted to talk to you about is pathogenesis. And if we look at leiomyomas, the principal symptoms, bulk pressure, infertility, and abnormal uterine bleeding. Pain is quite uncommon in non-pregnant individuals. And indeed, from my perspective, when there is pain and myomas, it's likely caused by something else. And then pregnancy will be dealt with later by Diana. So bulk pressure is fairly easy to discuss. If we have these large myomas, they may put pressure on the abdomen. Even smaller, like that type 7, if pushed against bladder anteriorly or rectum posteriorly, can cause symptoms even if it's not that big. I want to spend a little time on the infertility side. What do we know that can go wrong? And I like to use this particular study that is really almost 30 years old from Australia, but it breaks down the tumors by, and I'm going to make these colored just to make it easier to see. As you can see, the controls are in the gray, and these are pregnancy rates, which are really chemical pregnancy rates, and implantation rates, which were clinical pregnancy rates in today's language. But you can see that what happens is that subserous had actually no impact on either of these. Submucous had the greatest impact, and intramural had some impact. So this tells us, or gave us a clue very early on, that not all myomas have the same impact on fertility. In fact, subserous may have no impact at all. And then it begged the question about what about type 3s? And is it the type 3s that were called intramural that actually are the ones that adversely affect fertility, whereas the type 4s, are they really not affecting it at all? So let's talk about this. A very nice study was published by Beth Rakow in Hugh Taylor's lab when she was a fellow about 15 years ago. And she looked at these, and you can see there's the control, this right here. Then there's the intramural, and they didn't really distinguish 3s from 4s because it wasn't even published then. And then we looked at these submucous, or she looked at these submucous myomas, and not only right over, directly over the myoma, but also elsewhere in the endometrial cavity. And what you can see is that the subserous, or the intramural, I'm sorry, and the controls were really fairly close together, whereas the submucous tumors had an adverse impact on endometrial receptivity as measured by HOXA10 levels and the vertical axis. But also note with that blue box that the impact was not only over the myoma, it was throughout the entire cavity. Okay, so there's this global effect largely regulated by TGF-beta 3. So if we look at this in this way, and we have 3 myomas of similar size, but there's a 4, a 3, and a 2, for example, they're producing TGF-beta 3, but it may not even get to the endometrium unless there's contact. So for example, in a type 2 myoma, this production of TGF-beta 3 reduces the levels of HOXA10, HOXA11, these expressions related to implantation, and so they may impair implantation once that embryo reaches the endometrial cavity. I want to just mention that it's not all endometrium. There may be effects on the contraction profile, particularly in the inner myometrium. And so there are data showing that patients without submucous myomas have a normal peristalsis, whereas those who do have submucous myomas, for example, have altered hemostasis. And that also can affect others or be affected by others. With respect to abnormal uterine bleeding, what do we know about type 3, 4, etc.? Well, the endometrium is different than anywhere else. And you're not expected to know this, but there is a lot of molecular activity in the endometrium that changes depending on where you are in the cycle and where if progesterone is being made. And I would encourage you to understand this, because that production in late luteal phase can adversely affect what's going on in the menstrual phase. And you can go to Professor Hilary Critchley's paper, which you can see right here, and for which I believe I have a QR code, and you can get a very nice description of this particular issue. And similarly, also in Hugh Taylor's lab, Donna Sinkler looked at this, and when there is contact with the endometrium, bone morphogenetic protein is downregulated, and this can change. For example, plasminogen activator inhibitor is less expressed. That allows plasminogen activator to be overexpressed, and in the fibrolytic cascade, more plasma PA is associated with more bleeding, less control. So our hypothesis is that when there is heavy menstrual bleeding that's related to the leiomyoma, it's submucous. Whereas if you see tumors like these, type 4s, 5s, 6s, and 7s at least, that the cause of the bleeding is likely something else: coagulopathy, ovulatory disorder, or AUBE. So there we have it. That's all I have for you, and I'm sorry how fast it went, but we look forward to questions at the end.
Thank you so much, Mac. Thank you so much for the scientific introduction, and we appreciate that very much. Yeah, please, I want to remind all participants to leave any question in the Q&A box, and we will answer this later, and Dr. Munro is answer it later. And I'm really, really happy to introduce the next speaker. It is Dr. Yvonne Diaz-Yamal. She is a gynecologist and obstetrician, of course, but she's a specialist in human reproduction and gynecological endocrinology. And she has been trained extensively in Paris, France, and also holding a doctor of biology, showing her broad scientific background. She is currently the scientific director of fertility unit medically assisted procreation of the Mali Clinic in Bogota, Colombia. And she is the ex-president of the Colombian Federation of Societies in Obstetrics and Gynecology. And is the previous coordinator of the Committee of Reproductive Medicine, Endocrinology, and Infertility of Figo. And in this position, she has also influenced our toolbox group, and has been very influential on that. And she is currently the director of the Division of Sexual and Reproductive Health and Well-being of Figo. So, Yvonne, we are really happy to have you here, and yeah, please go ahead.
Thank you very much. So, for this conference is about the medical treatment for the fibroma. This is important because in some cases it's very, very important to start the medical treatment in myoma. For symptomatic relief, bleeding control, reduction in fibroid size, and improving infertility. So, which possibility we have? For symptomatic treatment, we have the non-steroidal anti-inflammatory drugs, NSAIDs, antifibrinolytics, oral contraceptive, and levonorgestrel intrauterine device is possible. And how is the control? For non-hormonal asymptomatic treatment, the tranexamic acid is one possibility to promote clotting and therefore reduce menstrual blood flow. It's more effective than placebo and no NSAIDs, but its efficacy in controlling bleeding related to uterine fibroid is not well established. So, the other possibility is non-steroidal anti-inflammatory drugs, That is the inhibit cyclooxygenase and therefore reduce the production of prostaglandins, which are elevated in excessive menstrual bleeding. Non-steroidal anti-inflammatory reduce both pain and blood loss in women, but not have any effect on the size of the fibroid. So the possibility, the hormonal treatment are, for example, oral contraceptive. Many use, they have demonstrated clinical efficacy for the treatment and prevention of menstrual bleeding disorder and menstrual-related pain symptoms. We can use the oral contraceptive before to myomectomy by hysteroscopy in submucosal myoma. The levonorgestrel intrauterine device, there is evidence indicated its effect in reducing menstrual bleeding without altering the size of the fibroid, in addition to an improvement in hemoglobin levels. In 2009, the FDA also approved the levonorgestrel intrauterine device for additional use to treat heavy menstrual bleeding. A prospective comparative study to demonstrate a statistically significant reduction in the blood loss, but no statistically significant reduction in the myoma volume. Dr. Malcolm to explain about how the estrogen and how the progesterone produce increase of the volume of myoma. For that, for estrogen and progesterone can to increase the volume, we can to block the possibility the estrogen progesterone reduce, and we can to reduce the myoma size and the symptoms. For example, with generase agonist. Generase agonist can to use for 4 or 6 months and reduce and decrease 35 until 65% in size in myoma. And can you use, for example, for before myomectomy with increased hemoglobin? Of course, only we can to use for very short time because it's block the estrogen and can produce the flush loss. So Cochrane said us the preoperative medical therapy before surgery for uterine fibroid is clear evidence that preoperative generase agonists reduce uterine and fibroid volume and increase preoperative hemoglobin levels. The only agent approved for FDA is in USA was leproid acetate agonist for improvement of anemia, preoperative only for short term, 3 to 6 months. The other possibility is oral generase antagonist. Oral generase antagonists are extensively studied now for the treatment of heavy menstrual bleeding associated with myoma, including elagolix, relugolix, and lisagolix. The elagolix supplemented with estradiol and norethindrone acetate was recently approved by FDA as first oral treatment for myoma associated with heavy menstrual bleeding. The elagolix have many studies to improve of course, the blood loss and decrease the size of myoma. And we can use with add back with estradiol 1 milligram and noritestosterone acetate 0.5 milligram. Many studies with relugolix and elagolix demonstrate the reduction of the fibronetic production, statistical significance. How relugolix, can you see here? And with elagolix, can you see here? The study de Liberty can to demonstrate not only the improve of the heavy menstrual bleeding after the weeks with use relugolix and no change in densitometry within lumbar and total hip. For the quality of life with relugolix combination with estradiol and noritestosterone acetate, you can see a statistical difference in symptom severity score with relugolix for 24 weeks and health-related quality of life total score, a statistical difference with use of relugolix. For that, NICE as the recommendation, relugolix estradiol noritestosterone acetate for treating moderate to severe symptoms of uterine fibroid. The recommendation is an effective non-surgical treatment, is taken orally. There is no restriction on treatment duration in the marketing authorization, in contrast with NRH agonist. It is well tolerated and it's preserved the uterus, in contrast to surgical option. Now, the lesarogis is a new generation antagonist under investigation for the treatment of endometriosis and uterine myoma. The Primrose 1 and Primrose 2 is a specific study for myoma and significantly reduce not only the blood loss and the size of the myoma. You can see, for example, in this study, 2025, reduce statistical significance with 100 and 200 milligrams with lesarogis versus placebo. The other possibility is a selective progesterone receptor modulator, because you know now the progesterone can increase the size of myoma. The selective progesterone receptor modulator induce apoptosis, inhibit myoma cell proliferation, and we can use for long term how lulipristal acetate, mifepristone, azoprisnil, vilaprisan, and telapriston acetate. Is hard Cochrane with the selective progesterone receptor modulator said as is no difference between leuprolide acetate and selective progesterone receptor modulator with respect to improve quality of life and bleeding symptoms. So we can see here the reduction of size of myoma with this selective progesterone receptor modulator. Of course, all knew the recommendation of FMI about the restricted use because can to produce the problem, the liver. So is with recommendation and restrict use, the SPM. For conclusion, we have variety of possibility cause of myoma. It's possible to therapeutic conservative in this patient. The management is less invasive. And every day we can find the newest therapies for medical treatment in patients with myoma. Thank you very much.
Thank you very much, Yvonne, for your talk about covering hormones and more, the current medical treatments for fibroids. For all participants, you are requested to leave your questions. And a lot of these questions we are answering right away in the Q&A box. But so I'm happy to introduce the next speaker. This is Dr. Joseph Njagi. And I'm really happy to introduce you, Joe. Dr. Njagi is an endometriosis specialist and minimal invasive surgeon from Kenya. He has a leadership role in leading centers in Kenya. He's vice chair of the Kenyan Society of Endoscopic Specialists and a founder member of the Pan-African Society of Endometriosis and also the African Center for Endometriosis, ACE. He is currently serving as director of the Third Park Hospital and the Maple Grove Gynecological Center in Kenya, which focus on multidisciplinary treatment of endometriosis. He is one of our board members in the Minimal Access Surgery Committee of Figo, and as such, he is contributing to the Figo's toolbox on fibroids. And he's a dedicated minimal invasive surgeon and as such, also a specialist on fibroids. So I'm really happy to announce Dr. Njagi's talk, Knife or Not, Surgical Decision-Making in Fibroids Management. Please.
Yeah, thank you so much, Professor Ivo, for the great introduction. And it's really a great pleasure for me to be part of this wonderful webinar tonight. Most so importantly, because this is a condition that affects up to 80% of African women. And what really gives me a bit of pleasure is this is a condition that I feel sometimes in the continent of Africa is not given the attention that's really necessarily required, considering some of the complication like heavy menstrual bleeding. And I think having my conversation following Dr. Diaz's presentation on medical treatment, I still find it's quite interesting because some of the new molecules, the GnRH antagonist treatment is still not locally available in most parts of Africa. So we also need to mention that access to medical treatment is a challenging to a continent that I think has the highest prevalence on uterine fibroids. So having this conversation on a forum like, a Figo forum, I think it just gives me a lot of pleasure, and knowing that there's really hope for women who suffer most from these conditions. Now, this is just the outline. I'll just be talking mostly on surgical management of uterine fibroid, which I really feel by far is the commonest option of treatment offered to women in this particular part of the world. Just a little bit of introduction. I know this has been mentioned. We see the prevalence is quite high. Incidence in Africa is about 80%. Of course, the good thing is that we know most of these tumors are quite innocent. They are benign. And when they are benign, we really don't need to do much about it. It's something that we can do watchful waiting. Unfortunately, a good percentage, about 50% of this, then will present with symptoms that Professor Malcolm has already talked about. The mostly one, which is quite detrimental, being the heavy menstrual bleeding or abnormal uterine bleeding. Now, when we discuss make a diagnosis of uterine fibroids. Approach, again, just has been mentioned, is it medical treatment? Who are patients who are going to benefit from medical treatment or other optional treatment? Of course, surgical treatment is what we are, medical treatment and surgical options are the two main options that are uptaken, not to mention the other option, minimal invasive HIFU uterine artery embolization. But for the purposes of our conversation today, we'll be looking at just medical, which has been talked about. And there are really different algorithms that have been put up. How do you make a decision based on what option of treatment? Again, there's what can be scientifically proven, but also we also need to look at some of the challenges that I've mentioned, and some mostly being access. Let's say, for example, for medical treatment, is it available in different healthcare systems? Of course, asymptomatic fibroids, we really don't do much about it. We can just watch this patient. And when patients have mild symptoms, the recommendation has been made medical treatment. But then quantifying of these symptoms, mild or severe, becomes a little bit of a challenging based on the patient's preference. What can be considered not bothering to a patient A might be quite concerning to another patient. There are patients who come to our clinics and they say, I have a tumor. I know it's not bothering me. It was an incidental finding, but I'm psychologically affected. I need it out. So patient preference should really be considered. Of course, most importantly, we need to make sure that we are not dealing with malignancy. Now, if you look at the second table here, it makes it a little bit more detailed in making decisions. And in most cases, the most important thing when we are deciding should be what is the patient fertility desire. And this is very important. Fertility is very important among African communities. So this has to be considered when you start having discussion. How soon do you want to get pregnant? How long have you been waiting to get pregnant? So this is a discussion that should be really held. And what are the symptoms? The patient needs to, what are the most bothering symptoms? If it's pain, you're going to give the NSAID that has been mentioned. Looking at the next slide, now the conclusion or the option of treatment then is a surgical treatment, then we find what are going to be the indication for surgery. Of course, if we have persistent symptom, just as has been mentioned, and not controlled by medical treatment, all patients are not keen to medical treatment or it's inappropriate to patient. For instance, there's different communities from this part of the world whereby uptake of contraceptives, of pills, is not well acceptable in different communities. So again, this has to be put in consideration when we are making options. Is it going to be medical treatment? If infertility is considered, there's recurrent pregnancy losses, which is attributed to fibroids, then I think surgical option might be considered to be appropriate option. If we have these rapidly enlarging tumors, we need to rule out possibility of malignancy, especially for patients who are peri or postmenopausal. And of course, uterine distortion, large compression symptom, this needs to be put in consideration when we're deciding. Most importantly, it should be patient preference. So the treatment should almost always be customized to or individualized to the patient's need and desires. I think so. Of course, we know that patient preference, when you talk to patient, most would really want to avoid surgery. So surgery should not be the first option of treatment. It was a little bit sad. I was talking to a patient from Jamaica. She reached out to me and she was saying, okay, you guys are seeing lots of fibroids in Africa. Most of the clinicians here I've seen, they're giving me option of a hysterectomy, and most likely patient fear for surgery. So that's very important. And 51% of patients really want to preserve their uterus, whether for fertility or not for fertility purposes. So what are the surgical options? Myomectomy, hysterectomy, or minimally invasive approaches. What are factors that are, we need to put in consideration? Again, I'm not going to go back into this. Professor Malcolm has talked about the Figo classification, and I think this was a really amazing work that they did. And we see that most of the submucosal fibroid are likely to be the most symptomatic. So we need to put in consideration the size of the fibroid, the number of the fibroid, location, and how accessible these fibroids are, where they can be accessed hysteroscopically, or open or laparoscopic myomectomy. What are the patient desire, future fertility, age, and could there be comorbidities? And of course, surgeon's expertise. There's a lot of conversation going around on laparoscopic myomectomy with mostylation. Do the numbers and the sizes of the fibroid matter? I think it's something that I think really matters. We get to see all kinds of fibroids here in Africa. You can see this is just a single fibroid. The size of the uterus was about 36 weeks. Again, you can see how massive these really tumors are. Of course, there's a patient who are most likely going to benefit from surgical option. Now, how do you determine the treatment? And I think this was an amazing algorithm that was suggested by Anderson in 2010. And you can see that when you're deciding uterine fibroid, are they symptomatic, yes or no? If they're not symptomatic, is there desire for fertility? If they are submucous, then you need to perform a hysteroscopic resection. If they're not symptomatic, or there's no fertility desire, then you really need to watch them. If then there's symptomatic, the next question that you need to ask yourself, is there a plan for future fertility? If the answer is no plan for future fertility, does the patient desire to preserve the uterus? And if the answer is yes, then you need to proceed and possibly give option of surgical treatment. If they don't have desires, a submucous is quite significant symptoms, then hysteroscopic resection could be considered. Of course, if there's future fertility, and we need to consider what is the location of the fibroid. Is it going to be hysteroscopic excision, or is it going to be a myomectomy where preservation of the uterus is considered? And for the patients who have no fertility and desire to preserve uterus, now we have different options of treatment, medical treatment, MRI, HIFU, and so on, surgical treatment, myomectomy being an option. When do we say there's contraindication for surgical treatment, non-knife? Of course, a symptomatic fibroid should not, if there's an incidental finding, no indication for a surgical option. If there are comorbidities, in pelvic infections, other conditions, coagulopathy, severe anemia, and of course, myomectomy should not be attempted during pregnancy. Again, we still need to emphasize that patient preference should be considered. What is our take home is that no one size fits all medical, surgical, or minimally invasive option of treatment, and must be patient individualized. Surgery is indicated for persistent, severe, or complicated cases, or when medical therapy fails, and there should be a discussion between multiple MDT, and the patient should be at the center of the decision making. These are my references, and thank you so much.
Thank you, Joseph, to talk about the surgical indications, the indications for surgery. It means a lot to us that you, coming from Africa, presents to us the global burden that may be the highest in Africa. And so thank you very much for your presentation. And so I'm really happy to introduce the next speaker. It is Professor Philippe Descamps. And Professor Descamps is head of Department of Gynecology and Obstetrics at Angers University Hospital in France, and since '99. And he's president of the Regional Reference Center for Endometriosis, but also a specialist in lyomas, fibroids, and a surgical specialist in this field. He has been member of various committees of Figo, has been a council member of Figo from 2015 to 2021, and he has been the vice president of Figo between 2021 and 2023, and he is currently one of the committee members responsible for the scientific program of the Figo World Conference in Cape Town later this year in October 25. Philip, we are really happy to have you here, and you will be talking about conservative or progressive image-guided therapies in fibroids care.
Thank you very much. Thanks a lot, Ivo. And I'm really happy. It's a great honor for me to be here today. So before we get started, I'm a surgeon and I will talk about non-surgery because I think it's part of the future for fibroids. So I want to thank my team, of course, who is working with me. As you all know, when you're a surgeon, we've been skipping from conventional open surgery to laparoscopic procedure, and now we're talking about extracorporeal non-invasive surgery. And of course, it's very important for the patients not to go inside their body and to have scars. So first point, nobody escapes from the progress. You know that we have been knowing a huge evolution for our telephones, which are doing everything today. They are our brain. And I want to stress on this slide because when something is new, you've got different kind of people. You've got the tech enthusiasts. They are jumping in the train right now. You've got the visionaries. They are the pragmatists, the conservatives, and the skeptics. So after my lecture, you have to think about in which color you are. So why do as surgeons worry about this? The answer is very simple, because every surgery has mortality and morbidity. So nobody can say I have absolutely no complications. So I will divide these lectures in 3 parts: embolization, HIFU, and radiofrequency. So back to embolization, you know that this is a procedure which is done by the radiologist. I will go quite quickly on this because in my country, embolization is contraindicated for women who are wishing for pregnancies because there is a risk of altered vascularization, and there is an increased synechia and placentation disorders. There is a very interesting study that has been published a few years ago about pregnancy after embolization, and they are quite optimistic about the possibility of having a pregnancy, but there are not so many papers, so it's still controversial. So now HIFU. HIFU is a new tool for us in Europe and in the States. You know that HIFU is a big machine. It's a new tool for us, but it's an old story because it has been launched in 2002, which means 23 years ago, and it's been approved by FDA more than 20 years ago. There are recommendations from UK, from the NICE, and from the ESGA, the European Surgical Gynecologists and Afanoscopy. So it's very important. So what is it? The idea is to have converging ultrasound waves focalized on a single millimetric focal point with an intense and immediate heat generated on the targeted tissue. And so the energy is 10,000 times superior to conventional ultrasound. So this is how it works. And it's a big machine, of course, and those waves induce an hyperthermia, ischemic necrosis, and intracellular cavitation. So this is just to stress on the safety. You see that if you put your hand in between the machine and the final spot, then you won't be injured because it's when the 2 waves meet, not before. So that does mean that it's very safe for the organs, for the intra-abdominal organs. There are many publications, many papers showing this. And roughly speaking, we can say that it's 50 times more safe than a surgical myomectomy. Even if we all think that we are the best surgeon in the world, we have complications rates, especially for women who are wishing pregnancy after a myomectomy, laparoscopic myomectomy, kind of uterine rupture. So how does it work? The patient is laying down like this, and there is a control by ultrasound and MRI. And this has been developed in 34 countries today. There are more than 410,000 patients who have been treated and 1 million non-tumor diseases. So it's not a new story. I mean, there are hundreds of thousands of patients which have been treated. So this is a real patient, and you see how it works. The sonographer or the gynecologist or the therapist, let's call him or her how you want, is as a computer, and you see when you press on the button, you got a red flame like this, and it's destroying the fibroid. So it's quite boring because you have to go from one point to the other, but it does work. So there are the recommendations that have been published in 2019, as I said, by the National Institutes of Healthcare in England and the SG Working Group. So let's go through those recommendations. I'm so sorry. So they all say that it's very interesting, that it's efficient, but it has to be performed in specialized centers with multidisciplinary team. So what are the advantages for the patients? The advantages are obvious. You have no scar. This is one of my myomectomies. You know, we are very proud as surgeons to do this, but finally we're just removing something, and it's not a big you know, deal and big a fantastic adventure. But for the patient, you keep the organ preservation, no need for blood transfusion, no general anesthesia, short hospital stay, fast recovery, and preservation of fertility. And for the surgeon, it's very interesting also because it's non-invasive. You're sitting, you're not standing for a laparoscopy. You have a precise ablation of the lesion. You have organ preservation and restoration of organ function. So it's really interesting for your patients. Fertility has been studied, so there's no myometrial damage, there's no ovarian function damage or endometrial function. So there are many, many papers about this, and you have very good results for fertility. So the results, this is a very important slide because in the NICE guidelines and studying all the meta-analysis and so on, you see that the volume of the fibroid will regress significantly of 50% at 3 months, but it keeps going on. You see 66% at 6 months and 83% at 24 months. So it's an ongoing process. And complications are very rare, and you have pain for at maximum 48 hours and less pain than in embolization, for example. So I think it's a very interesting procedure. It's non-invasive, it's effective. It's also working for adenomyosis, but it's not our topic today. So I think it's a very important treatment possibility for our patients. The last part of my lecture will be about radiofrequency. So I think all the gynecologists have to be aware of this because radiofrequency is more simple than HIFU. And you all know that you have two kinds of radiofrequency, either by vaginal route, either by laparoscopy. So by laparoscopy, you use a bipolar energy, and there are two major studies showing that it's working. It's very interesting. And you have a decrease of volume of, let's say, 65 to 72%. So it's really interesting. But you need to perform a laparoscopy, and of course, with some risk because of laparoscopy. The other option is transvaginal radio frequency thermoablation. And we did publish last year with my team a video showing the 10 key steps. And if we won't have enough time to go through everything, but if you're interested, you just go on fertility and sterility and you'll find it. So this is the video. If we can go to the first, I need some help now. So this is the machine, you see, and for anybody that has performed IVF or transvaginal ultrasound, it's really, really easy. Video is not working then, is it? Yeah, okay, here we are. So this is the machine, and then you put the needle like this, and then you put your vaginal probe inside the vagina. So the next step, please. And then we'll see, so you see how it works. You put the endovaginal probe in the vagina, and you see now the needle arriving in the fibroid, and it has to be positioned at least 1 centimeter before the posterior wall of the myoma. And then you press on the button and the machine is working. You have a diffusion of the monopolar current. So it's not really difficult for gynecologists, and the results are very good. Next slide, please. I'm nearly done. Next slide. So the advantages of this technique is the transvaginal access. Of course, it's easier than the laparoscopy. It's for 100% of the patients an outpatient procedure. You've got a very easy learning curve for a gynecologist. You've got 80% effectiveness in bleeding, volume reduction. You have got papers about this and very low reintervention rate. Next slide, please. So when you compare to uterine artery embolization, I think it's more suitable for patients with infertility, and of course you have less pain. Versus laparoscopic radiofrequency is much simpler because you've got vaginal access and you have a faster recovery. Next slide, please. If you compare to microwaves, it's more popular, and finally there are more papers about this technique because the literature review on microwave dates back to 2021. Next slide, please. So there are very few complications. There are in all the literature, you have no intraoperative complications and no severe complications. Next slide, please. And as for the intrauterine adhesions post radiofrequency, you see that the adhesion rate is 0%, so you don't have any synechia after this treatment. Next slide, please. So in conclusion, it's efficient, it's clinically efficient, and with a low complication rates and no severe complications. So I think it's very interesting. Next slide, please. So the take-home message for the two last techniques for HIFU and radiofrequency, they are both very efficient. You have lower complication compared to surgeries, shorter hospital stay, fewer complications, better quality of life, and of course, fewer complications during pregnancy. Next and last slide, please. So the message is that we have succeeded in abandoning or limiting laparotomies. Now we must limit laparoscopies to make a transition towards a medicine of the future, which is the ultimate goal of minimizing morbidity as much as possible while preserving fertility. In gynecologic surgery, image-guided therapies will play a major role in the future. I'm really convinced of this. Next slide, please. So thank you very much for your attention. And next slide, please. Of course, the next slide is to announce Cape Town meeting, where I hope there will be many of you will attend this meeting. Thank you so much, Mr. Chairman.
Yeah, thank you very much, Philippe. And thank you for reminding about the Figo World Conference. Actually, there are still tickets available, and you shouldn't miss it. And certainly, we will also talk on fibroids during the World Conference. And you find access via the online website. You can also scan the QR code, and you are most welcome. The last speaker, I can say last but not least, is Professor Diana Ramaswskaite. She's from Lithuania. And I just welcome you, Diana. Diana is the head of Department and Clinic of Obstetrics and Gynecology at the Faculty of Medicine in Vilnius, the capital of Lithuania. And she is the head of the clinical group of mother and child health of Vilnius University. She has been member of the Figo Childbirth and PPH Committee for years, since 2019 to 2023. And she's still associate member of this committee. She's also a member of the EBCOG, the European Board of College and Obstetrics and Gynecology, and has been a council member for this college. And she's president of the Lithuanian Society of Obstetricians and Gynecologists. She has published more than 140 scientific articles in international scientific journals. And her area of interest is reproductive medicine and perinatology and obstetrics. So, Diana, you are talking about complex care, navigating pregnancy with fibroids. Please.
Thank you for introduction. It's a great pleasure to be here and speak about myomas and pregnancy. We know that prevalence of uterine myomas in pregnancy varies between 1.6 to 10%, and the age of childbearing women is increasing, and we have more and more pregnant women that are presenting with fibroids. Of course, we have challenging questions. Should we do something before pregnancy, for example, myomectomy, or we will have pregnancy with fibroids? If we do myomectomy, of course, we will have concern about uterine rupture during pregnancy, and this decision should be taken on the individual basis and depend on the age of the patient, of course, on severity of symptoms, past reproductive history, and others. Usually, if we have pregnancy with fibroids, they are usually asymptomatic during pregnancy, and the most common symptom is the pain, which increases with increasing size of the tumor, and typically it is at the end of the first, at the beginning of the second half of pregnancy. Other clinical symptoms, pelvic pressure, vaginal bleeding, mild leukocytosis, fever, nausea, and vomiting are rare. And usually symptoms are associated with red degeneration, and it is due to peripheral venous thrombosis. If we have painful fibroids, we will start conservative management, and we prescribe non-steroidal anti-inflammatory drugs, usually for 2 days. And we should remember that FDA recommends avoid the usage of non-steroidal anti-inflammatory drugs at 30 weeks and later. And if we have a pregnancy from 20 till 30 weeks, we should use the lowest effective dose and for shortest duration period. Now we will speak about complications during pregnancy. Preterm birth, the risk of preterm birth, preterm delivery in pregnancies with fibroids increases up to 1.5 times. And it's more frequent with multiple fibroids and fibroids that are greater than 5 centimeters. Despite we know that we have higher risk for preterm birth with fibroids, but if we have pregnancy only with fibroids, there are no other indication for monitoring cervical length. We should not do this during pregnancy. Other complications, placental abruption, the risk of this complication is increasing up to 2.6 times, and it's usually more, we can find this complication in women with submucosal and retroplacental myomas, and of course, for myomas that are greater than 7 or 8 centimeters. The other complication, malpresentation, also increased up to 2.6 times. Also, it is more often found in women with large submucosal fibroids, multiple fibroids, fibroids that are located in the lower uterine segment and larger than 10 centimeters. Placenta previa, also the risk is increased 2.2 times, and also with fibroids greater than 5 centimeters. The results of meta-analysis showed that women with uterine fibroids experience a significantly higher risk of cesarean delivery, also till 2.6 times, and it is due to my mentioned problems that occur with fibroids. Malpresentation, placenta previa, placental abruption, and others. The data from meta-analysis showed an increased risk in postpartum hemorrhage also, and this risk increased till 3 times. And we have higher rate of postpartum hemorrhage, great estimated blood loss, especially with fibroids when they are located in the lower part of the uterus, and also if we have large fibroids more than 5 centimeters. Other complications, has dysfunctional labor, fetal abnormalities, uterine incarceration, urinary tract obstruction with urine retention, or acute renal failure, puerperal uterine inversion, pyomyoma are extremely rare. Such complications as peritemporal labor rupture of membranes, fetal growth restriction, fetal demise, or preeclampsia even probably have no increased risk in women with fibroids. Surgery for symptomatic fibroids is usually delayed not only after birth, but after breastfeeding. And the main indication for myomectomy during pregnancy is abdominal pain, not responding to medical treatment, and when we use conservative management more than 3 days. Other indications can be torsion of pedunculated fibroids, decompression of pelvic organs, or rapid growth of fibroid. Most women with leiomyomas will have successful vaginal delivery. And if we plan vaginal delivery and no other indications to induce labor failure, we can wait for spontaneous labor. Cesarean delivery is performed only for standard obstetric indications or that indications that occur due to complications associated with fibroids, malpresentation, placental abruption, and others that we have discussed. If we perform cesarean for any indication, cesarean myomectomy also should be generally be avoided. Due to greater risk of hemorrhage, use of blood transfusion, and longer hospital stay. But we have some observational data that suggests that cesarean myomectomy is possible without a high risk of life-threatening events, and if the obstetrician had appropriate expertise, appropriate patients are selected, and also blood products are available. So, summarizing my talk, I would like to highlight that usually the impact of leiomyomas on pregnancy is minimal. Most complications occur with multiple leiomyomas, retroplacental leiomyomas, and myomas greater than 5 centimeters. Complications include degeneration or torsion of leiomyomas, as well as increased risk of pregnancy complications, such as preterm labor and birth, placental abruption, malpresentation, placenta previa, cesarean delivery, and postpartum hemorrhage. Most women with leiomyomas will have a successful vaginal delivery. Cesarean delivery is performed for standard obstetric indications, and cesarean myomectomy should generally be avoided. Thank you for your attention.
Thank you so much, Diana. And actually, I thank all the speakers to be in time in such a brilliant manner. So we have time to discuss. Many of you, of the participants, have put some questions in the Q&A area, and I think I just want to start with Diana, because we are talking about pregnancy, and our patient comes to you after embolization. I mean, how long would you recommend this patient to wait for conceiving?
Thank you for the question. Many sources recommended a minimum delay of 6 months, but there are no really good evidence, high-level evidence, what is optimal delay. And it should be consult on individual approach. And as Professor Tom said, it may be even to look for another method of treatment for myomas, not embolization.
Thank you. And Professor Munro, Mac, what do you think type 3 and 4 fibroids, they cause heavy menstrual bleeding? Do we have to remove them to solve the problem?
Well, it's a question that has yet to be answered with reasonably good evidence. There is more evidence on type 3 myomas compared to type 4 with respect to fertility, and particularly with respect to the results of embryo transfer, and perhaps Yvonne can comment on that, but there have been inadequate studies to evaluate the impact of type 3 compared to type 4 myomas, either clinically or on the endometrial expressions that we know are associated with endometrial hemostasis. So that is, in fact, that was a topic in FNS that we had one of these fertile battle debates on a year or more ago. But at this point, we just don't have an answer for you that's based on evidence.
And if you find a fibroid that is very close to the fallopian tube, to the connual part of the tube, and the patient wants to conceive, do you recommend to remove it, or do you think the removal procedure is even impairing fertility?
Yes, it's a good question, and I know when we say that intramural myomas probably aren't associated, but if you curated a set of cases where there was intramural myomas that were adjacent to the interstitial portion of the tube, or that distorted the relationship of the ovary to the fimbria, I suspect that there would be infertility. The question you're asking is, in part, is that if that's unilateral, if that's in one case, is it reasonable to remove the leiomyoma? Is there some adverse effect of doing that on that interstitial portion of the tube because of the surgery or other ablative procedure that you're performing? And I don't think we have good answers for that. I know from my personal perspective, of course, with respect to IVF and embryo transfer, probably doesn't make any difference. But from a spontaneous pregnancy perspective, unilateral, one would question it. But as Joseph said, you have to individualize these cases with the best evidence that you have, realizing that you don't have evidence for all the decisions that you have to make.
Mm-hmm. And as you pointed to Dr. Njagi, Joseph, what are the fertility outcomes for women with huge uterine fibroids?
Yeah, of course, just as has been mentioned, much of what we see with distortion of the uterine cavity will be incidences of infertility, intrauterine growth restrictions, abortions, and so on. So when we have patients who have recurrent pregnancy losses as a result of fibroids or intrauterine growth restrictions, and this is something that we commonly see, especially patients who have multiple large fibroids, intramural type 3, type 0, 1 to 2 will cause infertility due to failure of implantations. When you have them large, then these are some of the complication that comes in. However, I think it's important to mention that our experience by far with surgical management, really good outcomes, putting in consideration there could be risk of adhesions, intrauterine cavity adhesions to the fallopian tubes, which will affect the ovum peak by the fallopian tube. So the skill and principles of myomectomy, it's quite important when you're managing these large fibroids.
Thank you. And then a question for Professor Decamp. Philippe, there's a question about relieving or resolution of symptoms after HIFU. If the patient is symptomatic and this is the indication for surgery, are there any considerations in patient selection? What kind of symptoms do you choose as an indication for surgery, or can you comment?
Yes, thank you for the question. I think that HIFU is a very good option, but of course not for all the patients. And Joseph is working in Africa, for example, where you have very huge myomas, and of course HIFU won't be a solution for all the myomas. But let's say for average myomas that we mostly see in North America or in Europe, let's say the example of a 2 to 5, 10 centimeters HIFU, the results will be very good. And this has been published for all the symptoms like bleeding, like pressure, and so on. So it's difficult to say HIFU for all patients. It's just for some patients.
Thank you, thank you, thank you so much. And Yvonne, Dr. Diaz, there's a question about the medical management. The GnRH also affects on ovarian function. So when do you choose the GnRH treatment, and is there any indication to distinguish between agonists and antagonists?
Yes, now the most used is antagonist because the product will have estradiol and acetate norelcesterone. So, but agonist only for short time because reduce the estrogen and can to affect the bone loss. So, but you can use the add-back therapy with low dose of estrogen to reduce this effect in the lost bone. But for agonists, only short time, and to antagonists, we can to use more time in the country without accepted. And of course, I have here another question about the ulipristal acetate. Of
Yes.
course,
Mm-hmm.
yes, of course, we have the restriction and recommendation. You need to make the measure of the level of the liver on the zinc because we have now the case with the Fowler hepatic. So now the agonist antagonist is the most more used in the medical treatment now for the size of the volume myoma.
Thank
Can
you.
I just make a comment about that?
Yes, of course.
So I think because many jurisdictions do not have access to antagonists, but they have access to agonists. And after that first month, basically their effect is similar. The difference is these formulations have built in the estrogen progestin add back. But you can, as Yvonne says, you can add back with a GnRH agonist and really get the same outcome. I mean, I've been using it that way for over 20 years, long-term therapy. And in the US, actually, with the add back of norethindrone acetate, it's approved for endometriosis for a year. And remember, approval doesn't mean that it's wrong to use it beyond a year. It just means that the FDA, the company has to go through the work of getting these package inserts. That doesn't mean that you can't use it. So I think really they're the same. One thing about GnRH agonists is that in a woman who's got anemia and heavy menstrual bleeding, when you give that agonist, you get a GnRH flare, which turns into an estradiol flare, which will typically turn into a bleed in that second or third week. And it's really important not just to counsel the women, but actually to try to prevent that bleed from happening, either with the use of a progestin or an AI. You can do any of those, but it's very critical. And so for that reason, it may be that an antagonist is better in the individuals who are anemic. But you can relatively easily prevent that flare using an oral progestin or an AI, and there's evidence in the literature to support that.
Yeah, thank you, Meg. And actually, I would like to address another question and take this question for you. It's actually we could respond, we need the fibroid toolbox, because the question is, in low middle income countries where details about Figo anatomical classification may be a challenge for most physicians, what advice would you put in consideration in making diagnosis and intervention? But apart from to recommend us to develop the toolbox, to have the actual diagnosis and treatment available all over the world, with repeated actualization, maybe you can comment on this?
Well, sure. I think, first of all, the first part of the question is that are there places in the world where it is very difficult? Well, quite frankly, if you have access to ultrasound, you should be able to figure this out reasonably well. So it's really a question of ultrasound accessibility. And a lot of the times it's difficult to sort out type 1, 2, and 3 with simple ultrasound, but cervical installation of either gel or saline, the sonohistogram can really help to sort that out. So I don't really buy that if you have ultrasound, you can't do this. It's just a question of doing it. And sonohysterography is very easy to perform. It's as easy to perform as placing an IUD or as doing an endometrial biopsy, etc. So that's my comment about that. We are, as you know, we have created this toolbox in draft form. So a lot of the people in this session, in fact, I think just about everybody is participating in that. And we hope to have a product that can be on your desktop, on your tablet, on your phone to help you see demonstrations of the things that we're talking about and provide you even more information than what we provided in this sampling in this webinar. So we look forward to having that up and running. When, Ivo? By the end of the year, something like that?
Thank you. Then I have a question that I would like Joe and Philippe to answer, because we have not talked about malignancy, but we know that our surgical procedure depends on our suspicion of malignancy. So maybe Joe, you can start, and Philippe, you can comment. You need to unmute.
Sorry,
Joseph.
Muted.
Yeah, great. And I think there's a question that's been asked. And we all know, following on another question I saw, brings again questions surrounding laparoscopic myomectomy and management of specimen retrieval. I think good standards and protocols in mapping the fibroids, mostly with MRI, it's quite critical for these patients, especially patients who have rapidly growing tumors over the age of 50, high suspicion index, as much as the prevalence is quite low. I'm not really quite sure we have validated statistic also in Africa, because there's quite a bit of a challenge in our data locally. But it's something that is very important, especially for older patients with consideration of fertility preservation, more so with now minimal invasive surgery.
And Philippe?
Yes, thank you. This is it's a major point, very important question. So I agree with what Joseph just said. And first of all, sarcomas are quite rare. In all the papers published about conservative treatments like HIFU embolization or radiofrequency, there are no cancers that has been missed. So because for one good reason, because they all had a very strict preoperative assessment with ultrasound and MRI. But I don't think, and again, most of those patients are young women. So, you don't have the 0% risk, but you have a very limited protocol with a good MRI.
And how about morcellation? I mean, if you go for minimal invasive surgery, morcellation is a must if you don't want to open up.
I'd really say with the FDA regulation of morcellation, this has, really became a quite controversial conversation. And where there's now in-bag morcellations, especially for mechanical morcellation. Again, I would still say it still being rare, it's a quite serious, the outcomes are, pretty undesired. And individualization, just as Professor Philip has mentioned, we need to have, criteria of high probability of malignant changes. It's quite rare for younger patients. We still, still in parts of Africa, and I've seen in Europe, there's still morcellation, mechanical morcellation. But recommendations is you do this in-bag morcellation is now recommended than uncontrolled morcellation.
Thank you so much, Joseph, and thank you all speakers for the brilliant and excellent presentations, for the time you have been sharing with us, all to aim to improve the awareness on the global burden on fibroids, just in the Fibroids Awareness Month of July 2025. And I'm really happy to have almost 300 participants all over the world. And now it brings me to the end of the webinar, because I have to share some closing remarks and some housekeeping remarks. The webinar will shortly become available on demand on the Figo Knowledge Hub. The link to the short webinar course is being posted in the chat and will be emailed to you shortly. You can use this link to obtain a certificate if you want after completion for this webinar by simply completing a short quiz and survey. You are invited to do so. Recordings will be added to this link 1 week following the webinar. Finally, and you see the slide, I'm delighted to let you know that registration is still open, as said, for the 25th Figo World Conference taking place in the beautiful city of Cape Town in South Africa in October, 5th until 9th of October. The website has been posted in the chat, which will provide you with more details about the scientific program. You can be sure that we are talking about fibroids again and again. And if you are interested in hands-on training, laparoscopic training, or if you are interested to visit video classrooms, we have a lot of offers for training and for sharing knowledge, for discussions. And so I thank you very much. And I don't want to close without thanking the organizing team of Figo, the Figo headquarters, and all people in the background you haven't seen, but you have seen that we have faced a perfect and professional technical equipment. And so this has been provided by Figo and the team and all people behind stages. So we thank these. And at the end, I want to thank the participants. You have been a great audience. And I hope you had you are happy to spend your time with us. And for now, have a nice time of the day. What time of the day it is now. And thank you for all. And I say goodbye.